So Engman followed up with another clinical trial. This time it's a small-sized, again, randomized controlled trial with a similar characteristics of patients, same protocol. What happened? The comparator was the woman who underwent dual suppression, which means the pill plus the long protocol, okay, and who received HCG based on the estradiol levels. What happened is, and they started luteal phase support on DEF collection again. What they showed is similar clinical outcome. Okay, if you start luteal phase support on DEF collection this way, it seems like it gives you similar clinical outcome. This was actually criticized in two ways. One, in the comparator group, in the dual suppression, some women may have undergone coasting, okay? And then Engman analyzed to answer this criticism, like what happened when you compared the luteal phase, the agonist trigger versus women who underwent coasting to isolate the effect of coasting. Actually, the coasting decreased pregnancy rates and live birth rates compared to the agonist trigger, so it's an advantage. And then they were also criticized with one other factor, which was, as they included women with polycystic ovarian syndrome, a substantial proportion of the study population, it was argued that women who already had high LH levels, high endogenous LH levels, might have benefited from this approach, since their endogenous LH might have rescued corpus luteum. So Engman did a further analysis of 316 agonist triggered cycles in their center, and with the multivariate regression model, what they found, it was true. Indeed, every single unit of increase in endogenous LH levels was associated with a 13% increase in the chance of having a live birth, again, clinical pregnancy. And women who really responded excessively, who could be polycystic ovarian syndrome, they benefited from this approach. Okay? So regarding summarizing the intensive luteal phase support strategy, I would say the jury is still out. We are not certain, okay? But it may improve cycle outcome if started right after collection. And women with polycystic ovarian syndrome with high endogenous LH levels and who have high endogenous estradiol levels may benefit from this approach. And actually, these are the same women who are really at risk of ovarian hyperstimulation syndrome and who can have even early OHSS if you give even a small dose of HCG, as I'll show you later. Okay. So the second option was trying to save the luteal phase with a small dose of HCG. I'll just go fast. The first trial in the context of an antagonist cycle came from Maiden. Okay. There was a small trial where they compared 3 groups. They were all normal responder women, either received 10,000 regular HCG or received the agonist trigger followed by a 1500 HCG bolus, either 12 hours later, the trigger, the agonist trigger, or 35 hours later. And they received regular luteal support with a small dose of estrogen. What happened is, the women in the 12 hours later group had significantly worse outcomes, and they concluded, you can't save the luteal phase if you give the small HCG 12 hours after the agonist trigger, because probably the receptors are not replenished yet. Okay, so they decided. You see, there's an obvious trend, though this is not statistically significant. They decided 35 hours was the optimal time, and followed up by a properly sized randomized trial involving 300 women, all normal responders. There are no polycystic ovarian syndrome women in this population. Okay, they either received 10,000 HCG or the agonist trigger followed by 1500 HCG 35 hours later, and they all received, micronized progesterone vaginally and 4 milligrams estradiol orally. What happened is, looking at the clinical outcome, is statistically similar with a small difference against the agonist trigger. Okay, and importantly, there were no OHSS cases in the agonist arm. However, you should be cautious because the average estradiol level on the day of trigger in this study is only 1600 picograms. They're all normal responders, okay? So I don't think you can generalize this no OHSS result to over-responders. Okay? Then, a series of publications followed, retrospective series, in high-risk women. One is from Peter again, and he reported on 12 women who had like more than 25 follicles and mean E2 levels of 5,000. And this is from Australia. This is published recently from Tremeland's group. They included 71 women with more than 14 follicles and mean E2 levels of almost 3,500 picograms. They gave either busulfan or leprolite, followed by 1,500 HCG 35 hours later. Clinical outcome is fine, like 50% ongoing pregnancy rate, and like 52% pregnancy rate, like 5% abortion rate, and only one case of late OHSS in each study, no case of early OHSS. Now I'll show you otherwise. I'm sorry, as this has been converted to PowerPoint from Mac, so this is why it overlaps. I'll present you two cases from McGill when I was a fellow. The first case was 27 years old, had polycystic ovarian syndrome. She was overweight with a BMI of 31. She was already put on metformin before the cycle to decrease her risk of OHSS. She was stimulated in a step-down regimen. Okay, the relatively high dose was due to her high BMI. Okay. As we realized she was over-responding, we decreased it to 150. E2 level was 5,500 on the day of trigger. She had only 11 follicles above 12 millimeters, but multiple smaller ones. We gave her the agonist trigger plus 1,500 HCG 35 hours later. We also put her on cabergoline. Okay. And we collected 62 oocytes, 42 were mature. This might be actually due to, we're used to aspirate even the smallest follicles. As we used to do a lot of IVM, we would aspirate even like 2 millimeters, 3 millimeters. As long as the needle gets into the follicle, we aspirate it. Okay. 3 days after collection, she came with bloating. Her hematocrit was increased to 53%. We had to drain 2.5 liters of ascites, okay? And we froze all the embryos. Okay. But you could guess, you could tell she had PCOS, overweight, high E2, okay? But nobody says this happens in the literature. The second case is even more interesting. 30 years old, not polycystic ovarian syndrome, regular cycles, no hyperandrogenism, but PCO appearing ovaries, still overweight, 29 BMI, given a smaller dosage, after 5 days of stimulation decreased even further. The estradiol level on the day of trigger is only like 3,200, 15 follicles over 12, the agonist trigger followed by 1,500 HCG 35 hours later, again put on cabergoline, collected 49 oocytes, and again 3 days after collection she came with bloating, hematocrit up to 51, 3.3 liters ascites drained. Okay, we actually later on collected other cases from different countries through our colleagues, because when we submitted these two cases, they keep being rejected from all the journals without any good cause though. Okay, so it happens even after the agonist trigger. Okay. So, despite the absence of, to summarize what happens with this approach, despite the absence of statistical significance, there's still a trend against the agonist trigger in pregnancy rates at the range of like 6%. It seems effective in preventing early onset OHSS, but not 100%. So you shouldn't feel like you're totally safe. You can do this to anybody. Okay? And I would actually consider intensive luteal phase support without the HCG support right after collection in women with high LH levels with PCOS or really over response. Okay? The agonist trigger only, without even a small dose of HCG and total cryopreservation, could be a safer strategy, as it would also prevent late OHSS. Okay, so I know how much I have left. I can just tell you a few things. If it's okay, like another 3, 4. Okay, fine. So to overcome these shortcomings, different approaches have been taken. One was, just adding a small dose of HCG simultaneously, not 35 hours later. There are 2 retrospective series, one from Shapiro again. They give 4 milligrams leprolite and give a small dose of HCG tailored to patient's weight. Okay, it ranges between 1,000 to 2,500. and they give this, they maintain their luteal phase support, modify progesterone and estradiol dosages to maintain estradiol levels and progesterone levels above these thresholds until 10 weeks. There's no HSS and apparently good clinical outcome. But I personally wouldn't feel comfortable with giving even 1,000 units of HCG. Okay, so this is again overlapping. There's another study showing similar thing. Just to keep it short. This is a recent study showing only HCG-based progesterone-free luteal support. Okay, so they recruited 15 women with one failed IVF cycle with the conventional HCG trigger. These are all normal responders. So they stimulated in the next cycle with an antagonist protocol. They gave them the agonist trigger, and they gave them 2 shots of 1500 HCG on the day of collection, and followed by 4 days later. No progesterone, no estradiol. So this HCG seems to save corpus luteum. Positive pregnancy test rate was 73%. Ongoing pregnancy rate is like 47%. Early pregnancy loss is still a bit high. Okay, but don't forget these are normal responders. So I wouldn't say this would be appropriate for women under high risk. Okay, but you can simplify treatment for normal responders. Okay, and how about recombinant LH following the agonist trigger? This is again a small randomized trial including 35 women undergoing elective single embryo transfer. PCOS excluded, normal responder. Fixed antagonist given either Ovitrel or 0.2 triptoelin, and they were given 600 milligrams vaginal micronized progesterone from day of collection to like if they're pregnant to 7th gestational week. And this group also received 600 units recombinant LH every 2 days, 6 times, so a total of like 10 days. So can you save the luteolytic effects? Can you prevent the luteolytic effect with recombinant LH? Apparently you can. Okay, so the pregnancy rates and the implantation rates, delivery rates are similar. So recombinant LH can be another means. As it would have shorter half-life than HCG, maybe this may be a better option. Okay, we need to see. The last thing, actually the second from the last thing I want to show is, remember what I told you in the beginning, some other people also tried to use the agonist trigger in the long protocol or with the microdose, okay? But what they did differently is, once they realized the patient was over-responding, they stopped giving the agonist and switched to antagonist. They reported on 3 patients, okay? The mean time, the range of time until the agonist trigger was 3 to 6 days after switching. The first patient also received 2500 HCG. So her results are not really reliable. It might be the HCG. Okay, so they collected 12 eggs, 5 were mature, 1 fertilized, transferred, mild early OHSS, and had a live birth. The second patient, she wasn't given any HCG, only the agonist trigger. Okay, after switching to antagonist in a long protocol cycle, they collected 32 oocytes, only 14 were mature, 12 fertilized. She didn't become pregnant with the fresh transfer, but later conceived with the transfer of a frozen toad embryo from this cycle. And the third patient had no eggs collected. Okay, so this is a small case series, but I wouldn't feel comfortable doing in my own patients so far. Okay, and one final thing is, can you encounter the empty follicle syndrome after the agonist trigger? Okay, this is a retrospective series comparing oocyte donors who received the agonist trigger versus similar characteristics patients who underwent with the IVF with their own eggs and who received Ovitrel, okay, recombinant HCG. Looking at the incidence of empty follicle syndrome, it's similar at 3%. So there's also the risk of empty follicle syndrome even after the agonist trigger. Okay, so and that might also be a good option for fertility preservation cycles due to its luteolytic effects, because for women who want to freeze their eggs or embryos who are diagnosed with breast cancer, we try to keep their estrogen levels low. So you can use an aromatase inhibitor, stimulate them in an antagonist cycle, and then give the agonist trigger. And after you collect the eggs, so that would bring down their estradiol levels, could be potentially safer. Oktay reported on this and reported similar, actually like even like lower estradiol levels and similar number of oocytes and collections. So in summary, the agonist trigger generates similar number of oocytes, fertilization rates, and embryo quality. Defective luteal phase can be restored to some extent with a small dose of HCG, but pregnancy rates are still a bit lower. Intensive luteal support can be a safer option for women with high endogenous LH levels. Cryopreservation of oocytes embryos following the agonist trigger yields similar outcome as after the HCG trigger. Cryopreservation can be a safer option as it would also prevent late OHSS. Empty follicle syndrome occurs at a similar rate. There is not much data regarding combination of the agonist trigger with other methods such as coasting or dopamine agonists. Thank you for your attention and patience.
Any questions?